thoracic artery right here that's going to run down the thoracic wall. This is going to supply the serratus anterior muscle. The next artery down is the largest branch off of the axillary. It's called the subscapular artery. And it's pretty large. It's about the size of a pencil. The subscapular artery descends along the margin of the scapula here, and then it sends a branch around the scapula, the back side of the scapula, called the Circumflex Scapular Artery, right there. So it actually comes down the outside of the scapula, and it will send a branch around the back side, like where the infraspinatus muscle is. It'll join up with other arteries I'll tell you about in just a second. What continues down the chest wall is the thoracodorsal artery. That's going to supply the latissimus dorsi. And then the last two branches off the axillary are the anterior and posterior circumflex humeral. These arteries come off, one comes forward, one goes posteriorly, and they wrap around the humeral head and supply the glenohumeral joint. So those are the branches of the axillary. These are all easy to find, very easy to find. Now that circumflex scapular, you see it right there? Here's the subscapular, there's the circumflex scapular. It's going to meet up with, there's the transverse cervical, there's the suprascapular artery right there. That artery goes through that notch, the suprascapular notch. Actually, it goes above. If this is the notch, and there's that ligament, you'll find the artery sits on the ligament. The suprascapular nerve, which is a branch of the brachial plexus, I'll talk about in just a second, that goes underneath it. So the Army goes over the bridge, the Navy goes under it. But you see that that suprascapular artery joins up with that circumflex scapula. Also, branches of the transverse cervical join up with the thoracodorsal. So they have, there's an anastomosis. Anastomosis means joining. Anastomosis, a vascular anastomosis around the scapula. Understand that if I have a gunshot wound or a stab wound or something like that, that damages this part of the artery, the axillary artery right here, or the subclavian even, I can tie it off. And I can still get blood supply to the upper extremity by going around through this anastomosis. So a gunshot wound between the thyrocervical trunk and the subscapular artery is just fine. I mean, you know what I mean. You can tie off that artery anywhere along there, and you can still preserve blood supply to the entire upper extremity chest wall. Between the thyrocervical trunk and the subscapular, anywhere along in there, it's just fine to tie it off. Okay, we'll take a break and we'll come back.
Went to Olecranon and saw you at work. Olecranon work.
Oh, it is? Yeah, I have like orange highlight and orange highlight means rewatch.
I think every day.
Yeah.
It doesn't have breakfast.
So locally, we bring.
Yeah, that's what he did.
So
I think breakfast.
the front, it comes
That's
down
what
all
we do
your
lunch every day.
neck liner,
And then we'll eat like a ton
and
of
then
the
turns
opposite.
So subscap connects, basically subscap connects with superscap. So in the front,
Do you mean subclavian? Super scapular is the nerve, I thought.
There's an artery.
it comes off of the
So it's these two.
Subscapular artery.
Yeah.
Suprascapular.
Subscap comes off of the subclavian and it is going to turn into thoracodorsal to create the lat, but it gives off a posterior.
But I would believe
here.
that. That's where,
Next.
that would make sense where it's less of a so.
That makes sense.
I need to move.
So this is in the front, right? So like coming out, it goes under pec liner into the arm here. Right around here, one branch is about to supply the lat, so that's subscap. And you're right by the subscap muscle. So you, it's just a name there. So your subscap here, that turns into thoracodorsal and it's lat. But and before that does that though, gets on the circumflex. And that circumflex.
I did that too. I stood up and I was like, I haven't
What's
sitting
already branched off from the
tired.
cervical trunk.
Okay.
Yeah, that makes sense now?
Yeah.
Because that top one is anterior and then that
Right,
one
and
is
that's
posterior.
the
So you can see it coming around from the
I was gonna go back
subscap,
and
just branched off.
Yeah, me too.
I went
down
because
I
I was
okay,
yesterday.
okay,
Yeah,
I think I understand.
Yeah.
I was like, oh, it's past the class.
Subclavian, and then it goes over here, and it's just subscapular, and then scapular comes back up.
Yes.
Ooh, and then that's the superscapular. Okay, that makes sense.
Or you
So
want
you'll
one
be in
which branch?
subscap.
Yeah, which one's like down, but it branches
that's
off into the, okay, thank you.
I just,
Thank you.
subscapular.
Transfer cervical and thoracic.
And then,
Did he say?
artery, the subscapular.
So was it the artery or the nerve?
That's what just like sharing.
So it says that the injury is between the thyrocervical trunk and the subscapular.
Yes.
What's the name of the ligament at the top?
So the ones that go around the humerus, it's just one that's
Hey, what was the name of the ligament in the notch?
yes. Like acromia.
I just call it the AC ligament.
Yeah.
World.
Acromicular, it's like the two things together.
Okay. I thought that's what it was, but I didn't know. And then, so, was it the artery or the nerve that goes above or below?
Artery, suprascapular is need to go underneath.
Arteries on top of the ligament.
Yeah, thyrocervical.
I did it in the brain, I can't know what that is.
The artery, other than the ligament.
All right, so
That is it for you?
not that picture, no.
It's acromioclavicular.
Yeah, that makes sense. I just call it AC ligament. I thought he said something else.
It's funny to listen to the
That's how we
conversations
call
we
it.
have before and after.
Okay, so artery is above.
Oh, is it running right now? Yeah.
Yeah, that picture is not doing it.
It's been so long since she's taken this. I don't believe her answers when she tells me. And then the day we were doing some stuff, and I was like, hey, mom, do you know this? And she's like, no, but I know how to meditate. And she started rattling along. I was like, I can't even handle this information. Don't tell me. But it was fun this morning because I was like, can you look at my phone? Because it hurts. She's like, yeah. And like, I told her, she's like, no, you don't have strap. Because I have it all. Now I know that.
You what?
Oh, my mom this morning, I asked her to look at my throat because it hurt really bad when I was working out, and she's like, okay. She's like, yeah, it looks a little red, but I mean, it doesn't look like nothing weird. It's like, cool. And I coughed, and she's like, well, we know it's not strep, and I was like, strep doesn't like cough.
I am charging the well, and this morning I just tried to write and it would
But what isn't like build up protein?
Well, that's the it's not the one that's in reaction to a specific medication. It's the blood thinners
yeah,
and the substance P and 3D kinase. It's just mucus. Yeah.
I know that real well. My doctor was every time I go in when I'm healthy. I'm like,
You just said,
wait, all my friends watch the Black.
that's Stacy. She's such a snotty person.
Says it's a sci-fi anthology series that explores a twisted, high-tech near future where humanity's greatest innovations and darkest instincts collide. That does not seem like something all my friends would watch. What the hell? My friends are like very, like, you know, not into that stuff. That's weird. Although we all watch Stranger Things.
I've never watched it either, but last night he was on the late night show.
What's his name?
Wait, you take Sudafed for the
He's on the
lab?
late night show. Every morning, like, he's like the president of like another show, but they're allergic reactions to something.
Oh, okay.
Not
They're not hives or anything like that.
Oh, they're joining the show.
Like I would get every morning. Yeah, that's what I'm talking about.
I used such candle, but it got
That's so
too ridiculous, so I stopped.
I mean, during the practical, I haven't noticed it so much right now, but during the practical, my nose was like burning, and like my eyes stung, yeah, it hurt.
They're combining.
I don't know if it's just because maybe I have like less of a, like a normal, like mucus layer, because it's all red and inflamed right now, so it might have just made it worse, but it was really bad during the practical. Maybe it's because he like got up and moved like around or something.
I know it was weird when we got to because I just see like tiny bones like don't breathe in because I don't want like to inhale.
Oh yeah,
inhale
yeah.
Dad's bones there.
Yeah, I know.
And so before he starts breathing,
I try to make myself like in a good distance from it, so I don't like get any.
I try to like he's like hold this. Yesterday when he was sawing off the top of the orbit cavity. Yeah. He's like hold this hand and like he was drilling from like here to here, and my fingers right here. And I was like,
Yeah, I did that too.
I was like, if it slips, he probably won't.
But I trusted him more than anyone else with the
The root of the safe
I've never
Hey Zach, does this have to be plugged in? Okay, I think it just fell off. Where does it go? On the back?
I really wanted to Stranger Things, so I followed it. I don't know. I want that color.
I'm sorry, I'm useless with
You're fine.
technology.
Yeah, because the battery only has 50 minutes. So, I mean, we're good for 50 minutes, but...
I'm just getting my hair. Yeah, if you move your arms to scalp, he wrote here too. Our bond over the trash one yesterday was not good one.
There's always audition for a shusher. Somebody who's really good at it, I don't know, loud whistler, I'll take auditions later. to go down. I have a piece of paper I'm going to pass out. It is a statement on academic standards agreement form. You know, at the very first day in class of orientation, we talked about the academic standards. There's a document posted for you on the OCU website, and there were links given to that. This is simply a statement that you need to, that states you have read it and understand it, and so you will sign it, date it, and this has to be turned back into Amber Hicks upstairs, and this goes in your file. If you do not, I want this thing back by the end of the day. There's no reason why you can't sign it and get it back up there that you look at it. If you ever read anything and don't know anything, then let her know, and it needs to be turned in by the end of the week, but you have a couple of weeks to look at that. If you do not turn this back in, I will track you down like a dog, and I will find you. Okay, so I'm going to just go ahead and pass these out. It just simply is a statement. I've seen it and I've read it, and just acknowledgement. Okay, and that's all. Go ahead and pass it on.
What is it, mine and it's that format with the last name, last, the middle, and the...
Yeah.
While he's passing that out,
You have a right to
going ahead. We deal with fractures of humerus. There are a couple of places that are particularly notable. One of them is the surgical neck that you see up here, and the other is a mid-shaft fracture of the humerus. These are problematic fractures because important nerves run in these areas. If you look at this illustration here, and this is what you'll find in lab today. Here's Terry's major. There's Terry's minor. That's infraspinatus there. And you can, by looking at this, you can see that Terry's major, why Terry's major is not one of the rotator cuff muscles. It attaches too far down on the humerus. The Terry's major and Terry's minor are there. There's a gap between the two. And then if you look at the triceps here, the different heads of the triceps, if you separate those heads, there forms a little space there. That's called the quadrangular space. The two structures in the quadrangular space you'll see poking out there, going to the back, are the axillary nerve and the posterior humeral circumflex artery. Okay? Everybody's got one. All right, good deal. The axillary nerve and the posterior humeral circumflex artery. So a fracture of the surgical neck of the humerus, you run the risk of axillary nerve injury. In an inferior dislocation of the shoulder, as that thing comes flying out of the shoulder there, there's a high percentage of axillary nerve injuries due to just a routine shoulder dislocation. Yes, ma'am.
Clinically, how would you know if they injured the axillary nerve?
That's a very good question. I was just getting ready to tell you that. Let me get Keely down here, because she has a t-shirt on. Or something. So, you pull that up over your shoulder. Yeah, there you go. So the axillary nerve is going to supply the deltoid. right? If she has a shoulder dislocation, she's not going to move. You're not going to check the function of the deltoid because she's in too much pain. And all of these nerves that we're going to talk about today end as cutaneous nerves. The axillary nerve, who's got the pencil, who's got the thing that writes on people? Who had the thing, you have it?
Sorry.
So here's the mass of her deltoid right there. Right at the base of the mass of her deltoid is this area. It's called the chevron sign. You know, like a private, that's a chevron. That area of skin is innervated by the axillary nerve. So you ask, how do you know whether or not the axillary nerve is injured? Just say, can you feel me touching you right there? If you can, the axillary nerve is intact. If you can't, it's been injured. The chevron sign. Inferior to that, in mid-shaft fractures, it's the radial nerve that goes in that spiral groove around the humerus, and an artery called the profunda brachii, or the deep brachial. You have the brachial artery that I told you about earlier. One of its main branches is the deep brachial. That goes posteriorly along with the radial nerve. So obviously the test question is, a mid-shaft fracture of the humerus is most likely going to injure what nerve? Surgical neck fracture is going to most likely injure what nerve?
What's the artery right there on the mid shaft?
Profunda brachii, the deep brachial. Okay, so here's the brachial plexus. So, although this looks daunting, it's really not. 5.
Sounds like a bullfrog. It sounds like a smoothie maker. I just remember one else. Weirdo. That's what you know.
Okay. To draw the brachial plexus, as you see there, remember the two Y's, two M's, and an X. Okay? So starting right here, two Y's.
Okay.
Two M's. There's one M. There's another. Two M's. And an X. There's the X right there. Now you just kind of connect a couple of things. Come out from C7 through that. Stop. And then continue there. That's the brachial plexus. Okay? So we have roots, upper, middle, and lower trunk. The divisions, anterior and posterior. cords. The three posterior divisions give rise to the posterior cord. Two of the anterior divisions give rise to the lateral cord. This applies up here. This anterior division gives rise to the medial cord, which is here. And then you have the nerves. The nerves are the musculocutaneous, the median, the ulnar, and the radial.
You have axillary on the slide. Do you want us to worry about that one there?
Well, yeah, but you gotta get all the branches. That's the main branch of the radial, of the posterior cord is the axillary. So that's the basic pattern. And then you gotta get all the little branches. You put on this one. We've got the long thoracic, suprascapular, nerve to the subclavian, lateral pectoral, upper and lower subscapular, thoracodorsal, medial pectoral, median brachial, and median antebrachial. Now you have the brachial plexus for real. So when you say throw in that little axillary nerve, I just couldn't wait to throw this slide. You're actually going to find all of these branches. And they're easy to find. Believe it or not. The three cords, they're big as Dallas. I mean, they're easy to find, and they wrap around the artery. Once you get this thing, once you get the fat out, the key to this whole thing, to finding all of these nerves, is to find that M right there. Once you locate that M, everything else, all you gotta do is just backtrack. And it all falls in place. You're gonna be impressed at how easy it is. Okay, any questions on that? The cutaneous nerve, I said the axillary is right there. I didn't lie to you. Right there. There is a couple of branches that you're going to find right here. The median brachial and medial brachial and medial antebrachial. Those are just supplying the medial side of the forearm and the medial side of the arm. The lateral antebrachial is a continuation of the musculocutaneous. And I'll show you why in just a second. Okay? That's pretty easy. And again, it's C4, C5, 6, 7, 8, T1. Superficial veins of the upper extremity. The venous plexus starts on the dorsum of the hand, which is where you're going to put IVs in. And then it coalesces into two main trunks. One of them is the cephalic vein that runs up laterally, right there, and dives into the deltopectoral triangle. If you have the deltoid here, the deltoid is here, and the pectoralis major muscle is here. That right there is the deltopectoral triangle. You feel it on yourself pretty easy. So that's a suit that nerve is in the subcutaneous tissue. If you remove the skin down to the deep fascia, it's going to be gone. But identify it, tease it out of there. That's the cephalic vein. And so that runs up laterally. The medial vein is called the basilic vein. That runs up to about the middle of the brachium and it dives deep to join the brachial vein. So understand you have deep veins. They would be the radial vein, the ulnar vein, the brachial vein. And then you have the superficial veins, the cephalic and basilic. And usually there's a vein connecting the two right here called the cubital. Some people call it antecubital. This is the cubital fossa of the elbow. There's usually a connection between the two. So when you're drawing blood on each other, 11 months from now, you're going to be sticking needles in these veins right here and on the dorsum of the hand.
We're gonna stick each other?
Yeah. Kathy's back there, yeah. If you'll notice on that rack, one of the racks over there, there's a little plastic bin that's full of tubes that are full of blood. It's their blood. I haven't thrown it away yet. So, yes, ma'am.
The cephalic vein, you said it's middle of the brachium and dives deep into the...
No. The cephalic vein runs up the lateral side of the
Cephalic, sorry.
upper extremity and dives into the clavy pectoral area here. The basilic runs up medially and dives in deep to join the brachial vein. Both of them are important, not just for blood draws, but for putting in a long-term catheter. You want to go in through the basilic vein. I'll show you that again. The axilla is, as it says here, it's a quadrangular looking structure, and it's really a continuation of the posterior triangle into the upper extremity. That's how, this is the axilla. It's that right there. This is the fossa. There's an anterior fold and a posterior fold to the axilla. If you look at the contents, this is what you're going to see today. Here are the, so right here I've got these 3 branches coming off the posterior cord. You can see them right here pretty easily. There's a couple, there are 1, 2, 3 right there. You've got pectoral nerves right there. Medial and lateral pectoral nerves that supply the pectoralis major and minor. They're actually kind of odd because this one right here is more lateral, right? But it's the medial pectoral nerve. The more medial one is the lateral pectoral nerve. Because they're not named for their position in the body, they're named from the cord from which they arise. This is the lateral cord right there. You can see that lateral pectoral nerve would have come from right there. So in the body, the medial is lateral, medial, because they're named from the cord, not their position in the body. And it's pretty easy. You can see the start right here of that M. Up, down, up, down. There's the M, the distal M. So I know that that's the ulnar nerve, that's the median nerve, that's the musculocutaneous. It's that easy. The posterior cord is behind the artery. Now, in this area, remove the vein. Get the vein out of your way. Just cut it out. If you look at the innervation of the walls of the axilla, it says the anterior wall muscles are innervated by the medial lateral cords. That's the medial lateral pectoral nerves. The medial wall of the axilla, which is the serratus anterior muscle, it's innervated by the long thoracic. This is the long thoracic right here. The long thoracic comes off of C5, C7 roots. The posterior wall is innervated by the branches of the posterior cord. The posterior wall meaning latissimus dorsi, teres major, okay. Subscapularis, all the stuff that's in the back. And this just says it a little bit differently. The top part does anyway. If you look at this right here, the cords of the brachial plexus supply the walls of the axilla. The musculocutaneous, all flexor arm muscles. So when you're talking about the flex, this is the arm, right? I'm not talking about down here. This is the arm. All of the flexors of this compartment are innervated by the musculocutaneous. When you get down to the forearm, the median nerve innervates all of the flexors of the forearm except 1.5 muscles that I'll talk about later, tomorrow. The ulnar nerve doesn't do much in the upper extremity until you get to the hand. A little bit here in the forearm. When you get to the hand, all of the intrinsic hand muscles are innervated by the ulna, except 1.5 groups. So if that helps you trying to get a handle on this, there you go. The pectoralis major and the pectoralis minor and the subclavius. Here's the innervation. Pectoralis minor is innervated by the medial pectoral nerve, which is located laterally. If you go back to this illustration here, there's the nerve right there. You see it comes through the pec minor, whereas the medial pectoral nerve bypasses it. It's on the medial border, so it does not contribute to pec minor. But then when you get down to pec major, both of them come through there to innervate pec major. The nerve to the subclavius gets that. If you look on this illustration, it comes off of the C5 dorsal root. The C5 root, that's the nerve to the subclavius. You're probably not going to find it, and that's fine. Actually, one of the cadavers, when we were looking at the phrenic nerve, somebody asked me what this nerve was here, and I didn't answer you because it would be screwy to try to bring this in and explain it, but it was the nerve to the subclavius. It runs across the scalenes. Serratus anterior is long thoracic. This thing holds the scapula next to the chest wall. Injury to the long thoracic nerve will let the medial or the vertebral border of the scapula swing out. And it's called winged scapula. And you can see this guy right here. He's not trying to do that. It's the way his scapula is. So injury to the long thoracic nerve, because it runs on the outside of the chest wall, injury to this, like to the back, like this, impact injuries can damage that long thoracic nerve and produce winging of the scapula. One thing about, before I go on, just to make sure I don't forget to say this, is that when you're delivering your first baby next year, if you wind up delivering a baby, it just depends on where you go, and mostly not going to be with an OBGYN. Most of you wind up delivering babies with a family medicine person out in nowhere, Oklahoma. So they just drop into the emergency room and there you go. But when you deliver your first baby, the head, hopefully, the head will come out first, and they'll be facing usually that way. and then the shoulders present themselves. So what you do is you take the head and sort of force it down to pop the anterior shoulder out, or your nearest shoulder. You pop it outside the vagina, boop, and then you lift up. It doesn't make that sound. I know, I see the mothers in this room looking at me in disgust, like, it's that easy, yeah. It is easy on our end when it's going right. So you pop the anterior shoulder out, and then once you get that out, you lift up and pop the bottom shoulder out. Once you get the shoulders past the vagina, it shoots out.
Sorry. Still.
So once you deliver the bottom, once you deliver the shoulders, that's the widest part. The rest of it just kind of, it's coming out. It comes out. The problem is, and this is where you cannot do this. When you push down and you get this anterior shoulder, people have a tendency to reach underneath there and get their finger underneath the, because the arms are like this, they get their finger underneath the posterior axilla and like pull from the bottom. Don't do that. Put your hand on the outside of the arm like that. If you reach under the axilla and try to pull it out like that, you will wind up ripping the brachial plexus, the inferior roots, off of the spinal cord. And they wind up with a brachial plexus injury, permanent brachial plexus injury of the lower roots of the brachial plexus. Somebody I know has that, was injured like that. So remember that. Here's the posterior axillary fold. We've kind of already been through this. The different innervations here, you'll see there's the relationship I told you earlier. There's the knots, there's the ligament, there's the artery, suprascapular artery going above the bridge, and the nerve going below it. To dissect this out to see it, all you have to do is take the supraspinatus and come back here and cut it all the way through, all the way down to the bone. And then just peel it off the bone this way. It peels off pretty well, like kind of like chicken breast. It'll just peel right off medially. And when you move it up far enough medially, you'll see the nerve artery and the ligament right there. Okay? Oh, I have chicken over there?
No, I'm not eating better.
All right, any questions about anything we talked about here? All right, so let's move on to the next lecture. Give me just a second. No, we're going to finish the second lecture, and then we'll do lab for the rest of the day. That's all right.
Yeah.
Because I think there are only just maybe 20 slides. Did I say that when I came down?
Yeah.
I thought I did. I want to know why Professor Brooks came in here and grabbed a handful of condoms out of there.
No, that's the fishbowl at the clinic.
That's what?
Those are the fishbowl at the clinic.
I know that fishbowl gets pretty well used.
What color should I get? Should I get blue, dark gray, or heather neat?
I'm gonna get the
I know, I like that one too. I'll try this one, but I think it's too dark.
So weird.
I like it. I like it.
Cute and summer with the white hair.
Good blue though.
Oh my god. He was born without a
Who is that?
Okay, the brachium in the elbow. if we look at the elbow, we know everything down now to the capitulum and the trochlea. If we look at the structures down here, there are two of them that I didn't mention earlier. One of them is on the radius. You've got the head, the neck, and then there's a tuberosity there, radial tuberosity. It's pretty prominent. It's attachment of the biceps tendon, part of the attachment of the biceps tendon. The olecranon is back in the plane of the board, and around the front of it, there it is up there. And then around the front there is a little lip there. It's called the coronary process. Coronary, If you look at the ligaments that hold the elbow together, there are three that you need to pay attention to. There's a medial and lateral, or radial and ulnar, collateral ligament, right there. That would be the ulnar collateral, and that's the radial collateral. The radial collateral, connecting the radius with the humerus, actually continues on around the head of the radius to form the annular ligament of the radial head. That's the annular ligament there. You can see the annular ligament there. So the globular head of the radius looks like that. So the annular ligament is just around it. It just holds it in place so that it can rotate freely around the capitulum.
And you said it's a continuation of what ligament?
Radial
It's a continuation of the radial collateral.
Okay.
The annular ligament is a continuation of the, if you look right here, there's the radial collateral. Right here, I'll come over to the side, you can see. There's the radial collateral. It just continues as the annular.
Okay.
And that's right next to the bone. These ligaments are right next to the bone. But they're easy to see. They're easy to define. Oh, and you can see the annular ligament right there on the other side of the ulna. The arterial supply of the elbow is like the arterial supply of the knee. There's a lot of collaterals that go around these joints. I don't really care that you know the names of them. If you look up here, you've got the brachial artery divided into the radial and ulnar down here. And then you've got radial recurrence, and then superior and inferior collaterals. All of these collaterals and all of this, don't worry about knowing any of that until you wind up on your orthopedic surgery rotation. You don't really need to pay. The thing is, the purpose for that is that when you bend your joint, you're going to occlude some of these vessels. And the purpose of all this collateralization, one of the purposes, is just to maintain the blood supply regardless of how your joints are positioned. If you flex the joint, you're going to pinch off the arteries on this side, but leave these open on the other side.
So your feet and hands will like, oh no, I guess it would be nerves and mine's get tingly if you sit in a certain spot for so long.
Yeah, that's pressure on the nerves. Or if you do cut off the blood supply, it can happen that way too. Now, some of your cadavers, I can tell you right now, some of the cadavers, this radial and ulnar artery split, will be high up here, maybe even as high as the axilla. So there's a lot of variation in where that split occurs. In most of the cadavers, it's going to be right past the elbow though. Now on the ulnar side, this is the ulnar side here, it gives off a branch called the common interosseous. The common interosseous. That common interosseous is going to divide into an anterior and a posterior interosseous. The posterior goes on the other side of the interosseous membrane through that gap that I told you about. Right there. There's the interosseous membrane. So the posterior goes between there, those anterior and posterior interossei supply the deep muscles of the forearm. The radial and ulnar arteries supply the superficial muscles of the forearm and will continue on into the hand. I mentioned earlier, April, you asked about this artery. Here's the profunda brachii right here. I think, did you ask about this? Profunda brachii, or the deep brachial. You see it going posterior along with what nerve? The radial nerve, mid-shaft fractures, and it continues and joins up with the recurrence from the bottom. Okay? It's pretty straightforward. The deep brachial is supplying the deep heads of the muscles of the arm. If we look at the brachial artery, the deep brachial is given off up here. There's the brachial artery, and it will dive deep to the tendon of the biceps brachii. You see where it runs right down the medial side of the biceps, along with the median nerve? So if you take your arm and hold it out like that, and you contract your bicep, there's the biceps right there, there's the groove right there. Put your finger right there, and you can feel the pulse of your brachial artery. When you take a blood pressure, that's where you put the stethoscope. Do not put the stethoscope over the cubital fossa, because you have to hear then through the aponeurosis and the tendon here. Put the stethoscope head right there. It's just amazing how many people do not do that. Can you feel your artery? Okay. If you can't feel yours, grab your partner next to you.
It's just a little medial of the cubital fossa, is that right?
Well, it runs, the radial artery runs right there.
Okay.
Runs right there, and it's coming right off the medial side of the muscle mass. This is good in December, when you're drawing blood from each other, because the basilic and cephalic veins are superficial to this. The cephalic and basilic veins are superficial to this. Understand, if you feel a pop with that needle as you advance it, as you're searching for that vein, you're probably not in a good place, because that pop is you penetrating the aponeurosis of this, and thank goodness the artery and nerve are deep to it and not superficial. Otherwise, there'd be a bunch of malfunctioning students running around. This is, remember I'm talking about bursa? Okay, this is an example of a bursitis you're going to see a lot. It's called the Olecranon Bursitis. And it produces this golf ball swelling right there on the, at the olecranon. I mean, it looks like it does look like a foot, and that's the calcaneus, but no, that's the Olecranon bursa right there. And it's right there between the bone and the skin. Now the extensors of the elbow attach right there, but it's just in front of that. Repetitive use, flexing, bending of the elbow can cause this fluid to build up in this bursa, and you wind up with Olecranon bursitis. To fix it, it's really easy. You just, you don't even anesthetize the skin. You just clean it, and then stick a small 1-inch needle in there and drain it off. Unfortunately, most of the time it'll come back, probably within the next 24 hours. To help it keep from coming back, once you draw off all the fluid, squirt a little steroid in there, and then put an ACE wrap around it, or one of those elbow elastic things, and that, the pressure keeps it from coming back. The definitive treatment, if it keeps coming back and is bothersome, the definitive treatment is to go in there and surgically remove the bursa. Do you have Olecranon Bursitis or something?
It was a guy I met at Disney World had the most gnarly one I've like ever seen. He had a Band-Aid on it like that was gonna.
The Band-Aid usually won't help.
It wasn't like a big Band-Aid, it was like a normal size Band-Aid, yeah.
Oh, yeah.
Doesn't hurt bad.
Wow.
You know, they're usually not painful because as the, you know, the first day when you were pinching your elbow, it doesn't hurt. And this is something that can be done in the comfort of your own home. The executive director of the Good Shepherd Clinic, you know, I was in North Carolina over Christmas, she kept calling me about her Olecranon Bursitis. I said, well, go to CVS, get an insulin syringe. It's not a big enough syringe. You're going to have to keep pumping it. But just put a little cotton, you know, do alcohol, stick a needle in it, drain it. That's all I would do.
When would you not drain it? Because I've seen doctors, whenever people come in, they won't even touch it and not drain it.
I always drain
Always
it.
drain
The thing about, okay, so you have to warn them, if I drain it, it'll probably come back. You need to give the elbow a rest. The other thing, though, is that if it's not infected, anytime you stick a needle into a joint or into a bursa, you run the risk of infecting it. I could turn your sterile Olecranon Bursitis into a septic bursa, which is going to be much more troublesome. But drain it, you know, it's fun, drain it. It's easy to do. It's so superficial, you're not going to hit anything. You can't hit anything, there's nothing there to hit. I mean, you could bounce the needle off the bone, but they'll probably tell you that you're doing that, it's to stop. Yeah. Most people who wouldn't drain that are just chickens. You wouldn't believe the number of people, number of providers that won't do things because of the risk of malpractice. You know, and there's no reason not to drain it.
Are there consequences to removing the bursa?
No, not whatsoever. This is a septic joint. It's not a good picture there, but you can see that joint is red, it's hot to touch, it's swollen. It has all of the cardinal signs of inflammation that we talked about yesterday. When you have a septic joint, that's when you usually, there are different ways to deal with. You're going to have to treat it with intravenous antibiotics. You may have to go in and clean out the joint. If it's a prosthetic joint, like a knee or shoulder or something like that, you got to remove the prosthesis. You cannot sterilize, make an infected prosthesis sterile. Nursemaid's elbow is, you know, the nursemaid watching after the little kid. If they grab the little kids, come on, Junior, and you do like that, and jerk them, you can take the radial head and pull it out of the annular ligament. And so the kid comes in with they're you know, like that. So to get it back in, all you have to do is convince the kid to let you do it. One, bend the elbow, and then as you straighten it out, you pronate and supinate, and that essentially rolls the head of the radius back under the annular ligament. That's all the treatment you need. It'll go in there. You don't need to, you might give them a little bit for pain relief, but you don't need to knock them flat with Versed like you do with the shoulder. So you can see this little kid right here. You just grab the upper and lower parts of the upper extremity and just flex and extend the elbow as you pronate and supinate.
That's only if like you forcefully like grab your child, right? We were told like, because I play with my nephews and I just let them like hold my hands.